Hello, everyone. Good morning, good afternoon, and welcome to Together for Health's webinar today. My name is Heather White. I'm the Executive Director for Together for Health, and I'm pleased to welcome you to today's session. Thank you for joining us. In today's webinar, we will hear from clinical and public health experts on the latest developments in the field of cervical cancer prevention. We'll review the types of screening approaches to consider, including HPV-based screening as well as other technologies, and we'll hear from experts about the role of HPV self-sampling and why this approach is particularly valuable in reaching underserved women. We'll also hear from colleagues who are currently implementing cervical cancer screen and treat programs in Cameroon, West Africa, as well as in Haiti in the Caribbean, to better understand how they are able to reach women in need, hear their program outcomes, understand the challenges they face, and hear from them about what opportunities they see in being able to reach more women in need of services. Finally, we'll open the discussion up for questions. A few words before we begin. All attendees are currently on mute. We will take questions after each presentation if time allows. If not, we will save questions for the Q&A sessions at the end of the presentations. I will be moderating the Q&A sessions. Please do feel free to write your questions in the chat box, and I will send those through to our panelists for their responses. The webinar is being recorded and will be available on our website after the event. And if you're interested in this topic and others from the field, we'd love to hear from you. At the end of the presentation, we will put up information on how you can get on Together's mailing list and contact us directly. So let's get started with our presentations. First and foremost, it's my pleasure to welcome Dr. Silvia de SanJose as our first presenter. Dr. SanJose serves as technical advisor on PATH's Sexual and Reproductive Health team. She is currently a lead scientist at the U.S. National Cancer Institute, collaborating on various studies to determine the accuracy of automated visual evaluation as a cervical screening method, and also involved in screening projects with women living with HIV. Dr. de SanJose is a medical doctor, family practitioner, and a preeminent researcher in the field of HPV and cervical cancer, with over 30 years of experience as a medical epidemiologist. She's published over 450 papers and has been a key investigator in numerous global research studies related to the topic of HPV and cancer, including some of the first studies that indicated there was a link between HPV and cervical cancer. Please may I welcome Dr. de SanJose and her topic, cervical cancer screening in low and middle income countries, new approaches leading to success. Silvia. Go right ahead.
Thank you, Heather. Dear colleagues, it is real pleasure to be here in this webinar today to explore how best we can improve screening for cervical cancer in low-resource settings, a disease that's almost fully preventable. Next, please. Can you move the slide? Yeah. Okay. No, the previous one, please. The second slide. Yeah. So out of 500,000 women that they are newly diagnosed every year with cervical cancer, 280,000 will die from this disease. This map shows the most updated mortality data that we have, and it shows the level of rates by intensity of red color. The most affected regions are in sub-Saharan countries. The map shows once more the great disparity that exists around the world. The differences across countries can be explained mainly by different access to screening. We hope that in a few years we will see the impact of HPV vaccination, which we cannot yet get it in mortality data. Vaccines should be probably the best asset helping to reduce these social geographic differences. Unfortunately, we know that still coverage in low-income countries is still poor, And I think that with the added epidemic of COVID, this disparity will remain for some time. Next slide, please. So we have the tools to scale up cervical cancer control. We have the vaccines, and we have issues like self-sampling, HPV testing, and a facility to treat the small lesions with thermal ablation. And I will try to focus here particularly in the self-sampling, HPV testing, and probably triage leading to treatment. So in terms of vaccination, we know that here is the most recent map that Pat had published. And you can see that there are many countries still in white, meaning that still there is no national vaccination program. And that's a real issue. Next, please. In terms of screening, which is the other second arm, now we have primary screening is primary prevention will be handled with vaccination, secondary prevention, so detection of lesions early before they become invasive cervical lesions can be mediated through screening. This map is one representation of what is the global aspect of screening in low and middle income countries, and that was produced by WHO STEPS. In this graph, data on ever screening among women aged 30 to 49 shows the poor spread of screening access in many countries. You know, you see here in the yellow, 70% is ever, countries responding ever having had screening. So WHO, in the move towards elimination, reducing really very much cervical cancer, aims to propose that in the next coming years, all countries should be able to report a coverage of a screening of 70% using a highly accurate test and providing at least 2 screening tests within the ages of 35 to 45. In the upcoming meeting in 20th of July, there will be several presentations that will update this scenario here, but still I can tell you that in low and middle income countries, the average of ever screening is below 30%. So we have a big task in front of us. Next, please. Okay, I try to move from mine here. So we have to decide, can we do anything better than what we have been doing so far? How can we decide a better strategy to screen our populations? And we have like 4 aspects that I consider that they are important. One is how we define our at-risk population, how we are going to screen, how we are going to manage screen positive women, and how we are going to treat those positive women. So the cervical cancer control scenario requires full consideration of what can be done and how we can adjust the interventions to the country possibilities in order to guarantee that any woman that is being screened and has a positive result can be managed adequately. Further, due to COVID pandemic, we need to provide that this scenario is run under a safe environment to prevent transmission of SARS virus in women that they are asymptomatic. So when we think about which women we should screen at this moment, we try to limit our age range. In high-income countries, women are being screened from 25 to 65, even 70 years old. But if we are going through a population that has never been screened, we will not want to detect many invasive cervical cancers that we cannot manage. So the main aim is going to try to detect early lesions so that we can manage with an easy treatment. Another issue that is going to be important is to understand how much HIV in my population I have, because I know that the natural history of HIV in relation to HPV is going to be different. We are going to have many more women that they will be HPV positive, and we have to know and understand how best to triage this group of people. How many of our women have ever been screened? If it's the first time we are screening a large group of women, what we are going to identify is many, many prevalent lesions. So we have a big burden. So if this is the case, we have to think carefully how we are going to screen initially our women. If we can afford the speculum exam, if we want to do speculum exam to all the women, or we can go through self-sampling if we use an HPV test, which would avoid many women to go through a gynecological exam and probably make this much more of a feasible intervention. How we are going to manage triage, I will talk a bit more about later. And notice that now we have ablative approaches, that they are low cost, that they are easy to manage, and that they can be used for at least 80% of the lesions we will detect in the screening clinics in non-HIV population. And so that these women that can be treated with ablation, they don't need to be referred to a more sophisticated environment to receive a surgical approach. Next slide, please. So I would like to insist that if we use self-sampling, it's because we have decided that we are going to use an HPV test. Okay, next slide. Here I'm showing you an important paper that was published in 2018 to convince us about the evidence that self-sampling was going to be a very good approach to perform with high accuracy our results on HPV. And that work was done by Mark Carving, who compiled all the literature and compared self-sampling with clinical collected samples in terms of HPV detection, and compare in two different analyses when the HPV tests were performed with what we call amplification assays or what we call PCR assays. The difference between both of them is that with PCR, with very little, very small viral load, we can really multiply this the DNA present in the sample, so RNA present in the sample, and the test becomes more sensitive to detect the presence of the virus. So, to make the story short, this slide shows this graph here, where you see the yellow line and on the left, and the blue line. You can see that they are both separated, and these are the comparison of sensitivity and specificity of the test being done using tests that were using amplification, and these were tests like hybrid capture or CARE-HPV that you may be familiar with CARE-HPV. And you can see the two lines are not overposing. They are not overlapped. While you go to the right, and you can see that there is no distinction between the two lines. The interpretation of these results is that self-sampling using PCR is performing exactly like clinical collected samples. Next slide, please. So I'm showing here our work that we did in Central America, where we use self-sampling collecting methods. We used at the time CARE-HPV because it was the only test that was available at low cost that we could afford. We tested over 230,000 women in these three countries, And you can see that when women were offered to use the self-sampling or could go to a clinician, the large majority of the women attending this screening project, they opted all for self-sampling. Over 72% in Guatemala, 73%, 96% in Nicaragua. And in Nicaragua, for example, more than half of the women were the first time to use self-sampling. There was a clear satisfaction of this because it was embedded in a project that as well was providing results with a limit of maximum 1 month. And so women were very happy with this new test, this new technology that seemed to give them a result that was not the reality they live when cervical cytology was being used. At the bottom of the slide, you see a graph, I think you see the graph, that in Honduras, there was a bit reluctancy to use the self-sampling. And by the end of the project, when they could not meet the target, they decided to go to use self-sampling. And immediately, in 1 year, they managed to screen 74,000 women, which is a large number for a small country. And so it really showed the ability of self-sampling helping screening coverage. Next slide, please. So why self-sampling is a good option is simple, low cost, increased coverage, increases equity, allowing to reach the most vulnerable, not easily accessing medical centers, and empowers women. Next slide. So the limitations of self-sampling is that sometimes there is a certain resistance by the provider to give this power to the women. It's clearly that women need to be trained, need to be reassured that they can do this work by themselves, that the results are going to be as comparable as those that the clinician is doing. We cannot run for the moment any morphology with this self-sampling. We need to pair this self-sampling with an HPV test, and if it's a PCR, that's much better. And we have operational challenges that we need to consider when we do that, so that we have to give back these results to the women. And we have to really make sure that there is a match between giving us the tubes and the samples and we providing back their results. Next slide, please. So when we talk about triage, here we have a big issue. Next slide. So far, what are the available strategies for triage? So imagine we have a set of HPV positive women. Generally is between 15 to 16% of the women will be HPV positive. If we are in an HIV setting, this will go as high as 40 to 50%. But let's stick with no HIV. What we have been using and promoting since 2014 was the use of visual inspection after acetic acid, but after some evaluation, we have seen that this approach is mainly, it has very little reproducibility. It changes very much across countries, settings, and providers. And in the global, the average accuracy is as poor as cytology in not high standard settings. There is a new approach that is called visual evaluation for treatment, in which HPV positive women are being examined in a rapid way to this regard that the woman has a big lesion, and try to see whether we can see the transformation zone, so the woman is eligible for ablation. And that's a quick way to manage women. And the example, the most prominent example, this is in El Salvador, where they are doing this since 2014. There is a new activity now in many countries with this availability of digital images with cell phones or portable colposcopes, where once you do visualization of the cervix, you can take an image and say, okay, now I see it better. Would this improve my accuracy? To say the truth, we still do not have any clear benefit of just looking at a better image will help to classify women whether they have a precancerous lesion or not. The new thing in which I am personally involved and working with many teams is that adding to the visual inspection an automated reading of the image using a model that is built under artificial intelligence and that will give an automatic reading of what is this image. Is this case looking like a precancerous, yes or not? Can this precancerous lesion or this lesion be treatable or not? The results, the preliminary results are excellent. Next, please. Here is the example of a paper that was published last year. Is the proof of concept of the NCI group working in Guanacaste, Costa Rica, where they took images from over 9,000 women. These images were based on cervograms, which is a very, I would say, high quality imaging that it's not anymore in use because it used film and it's not digital, but this was digitalized, and they use the whole complexity of building an algorithm comparing the images with the ground truth histology. So at the end, after all the training and testing, what they developed was an algorithm with an ABE severity score that would identify or provide a probability of the image being referred to a case or to a control. Next, please. So when they pull all this data together and they check for the value of the screening, what they compare is the sensitivity 1 minus specificity, and if the data would be like this diagonal line would be that no benefit of the testing, but what they got was an amazing result, which is the ROC curve, and the AUC, which is the area under this curve, is almost 1, is almost perfect. So they got really very excited that this algorithm was able to predict and to detect the prevalent and then the cases to be as well that appear in the follow-up that was over 7 or 9 years in this cohort. Because using this under a screening scenario would imply again to screen every woman through a gynecological exam, they explore as well what would happen if they would only do apply this algorithm among those women that they are HPV positive. And what is, you can see that the curve is a bit of less lower value. The area under the curve is now 87% instead of 100%. But still, this curve performs much better than any other triage test using the visual inspection, for example. So the idea is that this is a scenario that really is very promising. Next slide, please. And we are now doing a lot of different works. Because of COVID, we had to stop a lot of our field work. But what we are doing now is having a large networks to collect cervical images matched to histology data now within the screening and colposcopy settings. And because now we cannot get them through the screening using a regular cell phone, we are now working a lot on colposcopy images, trying to see whether we can improve our algorithm so that when we are able to go back to the field, we can really be fast. No? We are doing a replication of our results obtained in Costa Rica with other settings and as well using other different range of smartphones. Next, please. So just to conclude, I would say that self-sampling is probably a unique approach to reach a fast scaling up of screening in limited resource settings. We require an accurate HPV test. ABE may be an optimal and feasible intervention to assist cervical visualization, and we are very optimistic that this can be a reality soon. But we need to accumulate more evidence on the use of ABE, sorry for the spelling, and screening should be carried out at this moment under COVID-safe scenarios. And we don't stop saying it is very important that we don't add more hazards to our women that have rarely been screened. We don't want that together with the screening, we add them another infection. So if we cannot provide a safe scenario, we may consider preparing ourselves for a better planning and maybe delaying any new program 1 or 2 years. That is what probably will take us to control this COVID infection. And with this, I think my last slide is a thank you slide, because many people have been behind on this data here, although I went very briefly. But all the pathworks teams that work in Guatemala, Honduras, Nicaragua, and Seattle, the market dynamic team, and as well now with the group of NCI with the automatic visual evaluation team, and my colleague at NCI, Maxi. Thank you very much.
Thank you very much, Silvia, for that presentation. That was very informative, and as you say, really looking forward to seeing how the results from the work that you're doing starts to come together for the automated visual evaluation. Next, I'd like to welcome Dr. Joelle Faucom-Domgue, a Cameroonian gynecologist, a global health specialist who serves as a lead consultant for the Women's Health Program of the Cameroon Baptist Convention Services. Joelle has several years of clinical research and training experience in Africa, Europe, and the United States. He's led the development and implementation of innovative HPV-based cervical cancer screening strategies in limited resource settings, coordinated the establishment of effective educational programs to help African clinicians properly address cervical cancer in their communities, and contributed to the evaluation of newer, lower cost and rapid HPV tests for the use in high burden settings. I'd like to welcome Dr. Domgue and his presentation on HPV-based cervical cancer screening in Cameroon, challenges and opportunities. Thank you. Over to you, Joelle.
Thank you, Silvia. Hi, everyone. Can you hear me, please?
People are on mute, but yes, they should be able to hear.
Great. So thank you for inviting me to participate in this important webinar focusing on HPV-based cervical cancer screening. After the excellent presentation by Silvia, it is my privilege to share with you our experience in implementing HPV-based cervical cancer screening program in Cameroon. I will be talking on behalf of a great team I'm part of, and I'm very grateful to my collaborators for their thoughtful input. Slides, please. Just to give you a brief overview of Cameroon, Cameroon is an African nation on the Gulf of Guinea, situated at the junction between Middle and Western Africa, just above the equator. The population of Cameroon is about 26.5 million inhabitants, half of whom reside in urban areas. It should be noted that the majority of urban dwellers in Cameroon actually live in slums, which surround the big cities, and they live there under some sort of like condition of precariousness and poverty. The gross domestic product of Cameroon is about $1,500 per capita, making Cameroon a lower middle income country according to the World Health Bank. Cameroon has 2 official languages which are inherited from its colonial past, French and English. However, there are more than 200 tribes in the country with as many dialects. Cameroon has a high prevalence of HIV, which is estimated to be about 4% in the individual aged 15 to 45 years old. And this high prevalence of HIV is even, this prevalence of HIV is even higher among women compared to men. And this may contribute to the high burden of cervical cancer in the country, as we will see on the next slide. Next slide, please. In Cameroon, cervical cancer is the second most common and the second most deadly cancer among women after breast cancer. And then this makes cervical cancer a public health concern in Cameroon. The incidence rate of cervical cancer is 30 per 100,000 women, representing about 2,000 yearly cases. And this is about 4 times higher compared to the incidence in the United States, for example. And the factors that contribute to this high incidence of cervical cancer in Cameroon include the high HIV prevalence, as previously mentioned, the limited access of the population to HPV vaccination, but also the lack of organized and affordable cervical cancer screening program across the country. Today, it is estimated that less than 10% of women who are eligible for cervical cancer screening in Cameroon have ever been screened in their lifetime. Similarly, the mortality rate of cervical cancer in Cameroon is about 18 per 100,000 women, according to the WHO, which is about 8 times higher than the rate in the United States. This is due mainly to the fact that most women are diagnosed in Cameroon when the disease is already advanced and when the treatment options are very limited. Just to give you an example, there is only one functional radiation unit in the public health system in Cameroon, and this radiation unit is old and often breakdowns. So you can imagine the difficulty patient and their family can face. Next slide, please. On this map that was developed based on the 2018 global and data, you can see that Africa is the continent with the highest incidence of cervical cancer. And Cameroon has one of the highest incidence of cervical cancer in Middle and Western Africa. Although these statistics are alarming, they probably underestimate the actual burden of cervical cancer in Cameroon. And this is because many cases escape the standard health circuit in a country where healthcare is very expensive, health insurance is almost inexistent, and traditional medicine is still popular. As a result, many cases of cervical cancer and death from this disease are not counted in the official statistics. Next slide, please. Next slide, please. Cameroon is yet to implement an HPV vaccination program nationwide, and there are expectations that this program will start hopefully by next year. So the only effective preventive approach that is currently available in Cameroon is screening for cervical cancer. The National Cancer Control Committee of Cameroon has developed national guidelines for screening women in accordance with the WHO recommendations. The first national guidelines were officially released in 2007, and these guidelines have been updated so far, maybe just once or twice. So the screening tools recommended in Cameroon include cervical cytology, visual screening with VIA and VILI and HPV testing. Those are guidelines. On the field, however, there is no established program for cervical cancer screening that is implemented consistently nationwide. So most of the screening activities are opportunistic, and a limited number of women living in urban cities can actually afford the standard cytology screening and get pap smear from their doctor. In rural areas where women cannot afford the standard screening approach, visual screening is more available, and it is usually linked to treatment. This means that women are treated based on the observation of a suspect lesion on their cervix and without the histological verification of the disease. Okay, so now we are going to talk a little bit about a project we have in Cameroon. A couple of projects we are implementing in Cameroon on HPV-based cervical cancer screening. So the first project I will talk about was implemented in 2010 and between 2010 and 2012. And I was lucky to participate in this pilot project that was conducted even before the WHO officially endorsed HPV testing for cervical cancer screening. And this occurred in 2013. So in this study, we enrolled 540 women aged between 30 and 65 years old in 2 cities of the country. Women were educated about cervical cancer and HPV testing, and then they were given explanation on how to perform self-sampling with a swab. Those who agreed were invited to a healthcare facility where they collected vaginal specimen in a dedicated room without assistance of a healthcare worker. And in these years, no HPV machine was available in Cameroon, so the samples were analyzed in Switzerland using a real-time PCR machine. And self-sampling was well accepted by women in this particular study. Nearly 4% of HPV results were classified as invalid due to the insufficient DNA material in the specimen. This could be explained by the poor quality of specimen collection in some cases, but also and more likely by the heavy logistics of storing and shipping the specimen from Cameroon to Switzerland and the lag time between specimen collection and HPV analysis. Up to 27% of screened women were classified as HPV positive, and among these HPV positive women who were invited to come back to the hospital for follow-up, 1/4 did not show up. Next slide, please. So this graph depicts the age stratified prevalence of HPV in this population. And the resulting curve is bimodal, with the first peak in the younger age group and the second peak around the perimenopause. So in the second peak would be actually explained by an increase in the number of new contamination or by a reactivation of the virus that remains latent in the women. However, this is not the topic of this presentation, so we're not going to focus on that. Next slide, please. How did HPV perform in this population? HPV testing accurately detected all the cases of CIN2+ in HPV positive women who returned to the hospital for further investigation, and in a random sample of HPV negative women who were invited to come back to the hospital for visual screening. So the sensitivity of HPV testing was 100% and its specificity was 75% in this particular project. However, the sensitivity of a VIA was as low as 36%, and its specificity was around 90%. And this suggests that HPV testing on self-collected sample outperformed VIA for cervical cancer screening in high-burden setting. Next slide, please. So after this initial work, I had the privilege to work as a consultant for the Women Health Program. And the Women Health Program is part of the Cameroon Baptist Conventional Health Center, which is a faith-based and non-for-profit organization in Cameroon. On this slide, you can see the face of my key collaborator within the Women Health Program, Flora and Simon, Tom and Eddie, and we form a very nice team. So the Women Health Program hosts the largest cervical cancer screening program in Cameroon. It was started in 2007, and it consists not only on 11 stationary clinics in 7 of 10 regions of Cameroon, but also of outreach screening clinics in rural villages. To date, the Women Health Program has screened over 100,000 women for cervical cancer and treated over 4,000 women for cervical precancer. Next slide, please. So what are the characteristics for the Women Health Program? It is based on a see and treat approach using digital cervicography. At the beginning, digital cameras were used, but since about 5 years now, the Women Health Program has transitioned to smartphones that are cheaper and can be connected to internet, which facilitate the communication among the Women Health Program staff. So the Women Health Program actually use a fee-for-service model to recover costs, which help to sustain and expand the program. As previously indicated, screening is linked to treatment with thermal ablation or LEAD, and cases suspicious for cancer are biopsied and referred to appropriate facilities for further management. Consistent with the WHO guidelines, the Women Health Program has started to evaluate the possibility of transitioning from a visual-based approach to an HPV screening approach. Next slide, please. So in 2016, the Women Health Program was able to acquire one CARE HPV machine, which is a qualitative HPV assay, which detects 14 high-risk type HPV types. And the machine was actually developed for use in limited income countries, considering its lower cost, the possibility to provide results within about 3 hours of specimen collection, and the fact that the machine is battery powered. So we started using this machine. The machine was actually presented as a point of care technology by the promoters, and we started using it to see how feasibly it can be implemented in our program. Next slide, please. In 2016, we used the CARE HPV to examine the feasibility of self-testing for cervical cancer screening in rural area of the country. This report has been published last year in the International Journal of Cancer, so I will not elaborate that much on this work. But briefly, the objective was to assess the feasibility of screening and treating women in rural villages with self-collected CARE HPV tests, visual screening of HPV positive women, and treatment of all HPV positive women. Next slide, please. Next slide. The project was implemented in 3 phases, and I'm sorry that the font size is very small on this figure. But briefly, the first phases, which was the sensitization phase. In this phase, the staff conducted community education in the community, and community leaders were also informed about the project and encouraged the women to attend cervical cancer screening. In the second phase of the project, which was the self-sampling phase, the staff gave health talk on cervical cancer and obtained data from women who consented to participate in the study, in the project. And the nurse explained the stepwise self-collection process of vaginal specimen in English and the local dialect. And then they advised women to insert the brush into the vagina, specifically where they have sex. So kind of ensure that they don't confuse vagina with, let's say, with the urethra. And then eligible participants receive a kit, and then they perform self-sampling in a convenience place. So in the third phase of the project, the staff advised participating women to come on a specific day to receive their treatment, their HPV results, and those who were positive were invited to receive a treatment. And the treatment was actually guided by the visual inspection of the service, as previously described by Silvia in her presentation. Next slide, please. So what did we find in this project? 1,351 women were actually screened by CARE HPV in those villages. And only less than 5% of women reported having been previously screened for cervical cancer. The prevalence of HIV in the study population was about 4%. Overall, 15% of women screened in this project were HPV positive, and the prevalence of HPV was 3 times higher among HIV positive women compared to HIV negative women. Next slide, please. So we noticed some sort of complication of self-sampling in this particular project. And specifically, one woman inserted the cytobrush into her bladder. And unfortunately, the brush broke off in the bladder, but we were able to remove it surgically in a higher level facility without any complication. And in 2 other women, the cytobrushes broke off into their vagina, and the nurses were able to remove those brushes in the villages. So about 80% of women who were HPV positive were examined, and nearly 80% were also treated. Next slide, please. So in conclusion, self-sampling as well as thermal ablation are well accepted by women in Africa. And appropriate education on how to perform the procedure is critical to prevent some sort of complication as those we have described in this presentation. Same-day testing and treatment is difficult to achieve with care HPV screening in remote and rural villages. And with community engagement, sensitization, and organized follow-up, a high proportion of HPV positive women will come back for further assessment and treatment. I did not sort of like emphasize on the second HPV machine that we acquired recently, which is the amplifier analyzer, because we just started using it, and then we are still kind of learning how to use this machine. So with that, next slide, please. I'm gonna sort of like appreciate the contribution of my collaborators, and thank you very much for your attention.
Thank you, Joel. That was very informative, and we appreciate the insights. In the interest of time, I'm going to quickly turn to our final presenter, and I do want to say, for those of you who may have questions for anyone coming through, we're happy to take those questions if we can during the presentation. Otherwise, we can take them specifically offline and follow up with you directly. I would like to now introduce Dr. Vince DeGennaro, who will be offering insights on the program that he and his colleagues at Innovating Health International are implementing in Haiti. Dr. Vince is an internal medicine physician, an epidemiologist, and public health specialist who has worked in several countries around the world implementing public health programs focused on disaster relief and chronic disease management. He splits his time between Haiti and Miami, Florida, and the Department of Medicine at Florida International University College of Medicine. He is the founder of Innovating Health International and works as the medical director of Haiti Air Ambulance. As a staunch advocate for social justice, he fights to increase access to healthcare in developing countries, including to help build cancer programs in Rwanda, Haiti, and most recently in Somaliland. I'll now turn it over to Dr. Vince for his presentation on vertically integrated cervical cancer care in Haiti. Thank you.
Hi, everyone. Nice to meet you all. Thanks for coming. We're going to talk about our cervical cancer project in Haiti because it is vertically integrated. And that means that we do everything from top to bottom, from screening to prevention to treatment of advanced cervical cancer. We can go to the next slide. So this is Haiti. On the right would be the Dominican Republic, and that's what you're not seeing. Cuba is to the west, and the United States is just to the north. Port-au-Prince is the blue dot in the West Department, and the major cities of each of the 10 departments all have a black dot on them. And that's where we rolled out our initial cervical cancer screening project with government hospitals in 2016 and 17. Because of a lack of political buy-in, that program didn't survive long term. And so now we've pivoted to working more with other NGOs in order to move this forward. Haiti doesn't, while they have a written national screening program, there is nothing in practice for it, unfortunately. Next slide. Next. So statistically, this is the cancer. These are the cancers that presented to our cancer treatment center. So this is very different, obviously, than a prevention program. But you can see that most of them are cervical cancer. That's obviously owing to the high prevalence, but then also the fact that this is more easily diagnosed than endometrial or ovarian cancer. There are ways to get pap smears and to diagnose advanced cervical cancer in ways that you can't diagnose some of the other cancers. The other thing I'd like you to notice is the advanced stages that most women are coming in stage 3 and 4. That's across all cancers, of course, but for sure holds up for cervical cancer. And then also the death rates, about 35% with 8% loss to follow-up within the 2-year period. Next slide, please. So for under 30, about 20% of our patients are under 30, and the majority of them were female, and most of them, about half, had breast cancer. But you can also see that about 10% of those cancer cases under 30 were cervical cancer as well. Next. And then HIV, almost half had a known HIV status. Only 8% were positive. And of those with HIV, about a third of them had invasive cervical cancer. So there's that, that link between HIV and cervical cancer. Haiti does have universal access to ARTs, although compliance is questionable, and that certainly leads to this. Next. So we'll talk about our screening program. We've tried to do everything on a community-based level because, like I said, the national government isn't very strong. It doesn't have a lot of funding to roll out things. And we initially we were working with the local hospitals, the local public hospitals. We educated over 30,000 people and screened 7,000 at those 8 sites across the country. They were doing VIA and treating with thermocoagulation. We also did a lot of kind of field work going out into smaller rural areas and doing kind of education and VIA with referral for those women who needed cryotherapy after. And then 2 years ago, we launched a program in an industrial park to work more with the private sector in order to get screening done. And we educated about 7,000 women, screened 5,000 for breast cancer, 4,000 for cervical cancer, and found about 1,000 women with either positive VIA or positive HPV that were then treated with thermocoagulation. And again, we did a cancer awareness study in 2016 using community healthcare workers in 4 of the 10 departments around Haiti, and in order for us to better understand cancer care. And so all of these are just kind of examples of how we're using screening in the community, public hospitals, private business, and then also through kind of civil society for awareness raising, but all using community healthcare workers as the linchpin of the screening for community-based screening. Next, please. So for our program at the factories, we work with Share Hope, which is a group that works with the factories and does education with them already. So that partner was key in order for us to convince the factories to participate and then also provide the education for the women. We provided education for 25 women at a time, giving them a free lunch because they work 8 hours and they were spending their lunch hour getting educated. Those women who were eligible were then invited back the next day or the day after that to come and do a breast exam and a self-HPV sampling. We did the self-HPV sampling for women 30 to 50. Everyone who wanted one got a breast exam and were taught how to do a self-breast exam as well. And then anyone who was positive for HPV, we did do VIA, but regardless of the VIA results, we had elected to treat for thermocoagulation for every woman who was HPV positive, given that this might be the only opportunity to screen these women in their lifetime. Next. So our data collection is complete. Sorry for that. Like I said, we educated about 7,000 women. 4,000 women were eligible for HPV screening being in the age range, and 85% of those accepted testing. The majority of those who didn't accept testing were pregnant or had their period and didn't come back. Some were fired from the job. Some left the job. Some had recently given birth. Some had had screening recently. So of the women who were kind of truly eligible for an HPV-based screening at that time, it was about 97%. So about 22% were HPV positive, which is relatively high. And of those who were HPV positive, they all got a VIA, and about 12% of them were positive. But like I said, regardless, all women who were HPV positive got thermocoagulation. Next. Like I said, high rate of clinical breast exam. Choosing of the women who had a clinical breast exam, we had a doctor do a breast exam and then an ultrasound. For women with suspicious masses, 3 required a biopsy. We thought this was a good training for doctors and nurses, and we trained them to do the VIA and thermocoagulation. And as you can see, the high rate of acceptability of HPV screening and self-sampling behind a curtain at the factory. So next is to be able to do this in rural areas. Next slide. I'm not going to go through this, but I think we all know the benefits of kind of portable screening with HPV or VIA, mobile colposcopy, and thermocoagulation, which we're trying to push over cryotherapy, given how mobile it is and can be done anywhere, and is a whole lot cheaper than cryotherapy and Pap smear. Next. So for the treatment side, I'm not going to go through the algorithm, but we had women who came in with cervical cancer. They were triaged, they were tested, they were staged. Women who were stage 3 or below received chemotherapy. This is, we've done certainly more since this slide was made. Most of them, a significant number of them then progressed, and we had a doctor evaluate them to see if they were an operable candidate using clinical staging alone. Others got palliative chemotherapy, which we found not only lengthens life, but significantly reduces symptoms for the women, which has a huge impact on the women who are in their 30s, 40s, and 50s with young children and still working. Next. So we did radical hysterectomies, stage 1B2 up to 3B. The women all received 3 to 6 cycles of chemo. We basically stopped giving chemo whenever they were operable and operated. We did this for 47 women after neoadjuvant chemo, 7 cases of stage 1, 25 in stage 2, and 10 in stage 3. 3 of them who we thought were stage 3, when we opened them up, we found that they were too advanced intraoperatively and closed. We had 2 vesicovaginal fistulas and 2 with urinary incontinence that we later repaired surgically, and they were doing fine. And they had 1 woman with a wound that dehisced, opened up, and led to sepsis and death within 6 weeks of the operation. So that was our only really bad outcome. Also, we had 8 women recur with cancer during the time. Next, please. So in the future, next, please, we, like I said, are talking about vaginal self-swabs, talking about which the women can do anywhere, and we can just collect the tubes. We can come in with the computer-assisted colposcopy, like the AVE, like our other partners were talking about earlier today. I think the artificial intelligence is really going to have a huge step up, because then you can put these in the hands of community health workers instead of nurses and really get them out there more. And then battery operated thermocoagulation is also huge, because you can see the gun is very small, it's portable, it's on batteries, so you don't need electricity. You can treat 10 or 15 women at a time before recharging. and works really well and just as well as cryotherapy, and doesn't have any more side effects than cryotherapy does. The machine costs around $2,000 US. Next. So that's about it. I think, like I said, the future for us is to be able to get these mobile interventions out so that we can roll out more community-based screening. And that's all. Thank you very much.
Thank you so much, Vince. We appreciate those perspectives from each of you, knowing that it is a challenging area in terms of increasing coverage. But as you have all alluded to, we do have the right combination of tools coming online now and in the not so distant future to be thinking about how we can effectively scale up to increase the coverage rates that will be in line with the elimination targets set forth by WHO and colleagues. We're on the hour now, so I just want to close and thank all of the panelists and send out my sincere apologies that we didn't have a more formal Q&A session across with you all as audience members. Please do type your questions in the chat. We'll make sure to answer those offline. And we thank you again from the Together for Health team, and thanks each of these colleagues, and we will see you at our next session. Thank you all very much for your time. Bye-bye.